No.
Today we got some interesting stuff today. We're doing something kind of near and dear to our hearts. We're doing heart disease.
Yeah. And I thought we would just kind of talk about, everyone says, or actually rather the first question, that I often ask people is, do you have a family history of heart disease? Do you ever ask that, Chris, as a physician to your patient?
Oh my gosh, yeah, that's a big one.
Yeah. And what kind of answers do you get?
Sorry. Sammy, go lay down. Couch. Couch. Dog.
He can be in here.
Anything from a detailed list to I have no idea. But most people, if you ask for any sort of family history, it's usually they bring up heart disease of some sort.
Yeah.
It always seems to be cardiac in nature.
I mean, it's kind of what gets us all at the end, right? But see, I was actually thinking more along the lines of, I asked someone, whether it's here at Sapia or, back working in the ER, do you have a family history of heart disease? And they might say, well, yeah, my, mother's third great grandfather died of a heart attack in the old country in 1883. And that might be true. But the question is always, well, what kind of heart disease was it? So what does heart disease mean? Yeah. And then how does that really actually impact you? And that, I think that's what we're trying to get at today, right? Is just kind of go over for people what heart disease is and why you don't want it, and then what the different types are, just so we can have a little bit more nuance with our conversations. So what is heart disease to us then? I kind of think of it as being probably four specific types of heart disease. You want to take a crack at a couple of them there?
Yeah, and I like the way we kind of categorize them as well. There's the coronary artery disease is kind of the biggie that you always think of. That's kind of a plumbing issue, and we'll dive into these a little bit in more detail.
And that's basically heart attacks, right? So yep, coronary arteries feed the blood to your heart itself. Those are heart attacks, coronary artery diseases, heart attacks, and plumbing problems, clogged pipes. Mm-hmm. And then
there's heart failure.
Yep. So the pump's just not working with that one, right?
Yeah, exactly. You got arrhythmias. That's an electrical problem, we'll call it. Mm-hmm. And then there's the inborn stuff. The congenital stuff you're born with. Kind of another subclass.
Yeah, we probably won't talk too much about that. Because if you have that, you probably already know about it. You probably know more than most of your doctors about it if you're dealing with that long term. Let's start with coronary artery disease or CAD, as we call it in the biz.
Yeah, so this is the big one. This is kind of the one where we'll have the most to kind of interact with at Sapia in terms of prevention and treatment and those sort of things. But you think of it as coronary artery disease, and what the coronary arteries are is they're the blood vessels bringing that oxygenated blood to the heart, and then when they get narrowed or blocked, that is the definition of coronary artery disease. And usually that buildup is
what narrows or blocks them, Chris.
So usually what happens is you get the formation of something called a plaque. Okay. And it's kind of this fatty substance. It's a mixture of cholesterol. It could be, some calcium in there. And inflammation and inflammatory cells kind of build that up. And slowly it builds up on the inner lining of the wall of the pipe. And so that pipe then gets narrow and narrow and narrow and narrow, reducing the blood flow to the heart, and consequently as well, leading the heart to have to pump hard to try to get the same amount of blood through those narrowed pipes.
Is that why we spend so much time talking about cholesterol?
Exactly. Cholesterol, inflammation, a lot of lifestyle things that can contribute to this. So many things go into the health of your blood vessels. So.
And I was, because you're bringing up inflammation, I was just talking with a patient yesterday, and we had some borderline cholesterol issues. On a normal lab, it probably reads just like low risk or barely above normal.
Mm-hmm.
But then we looked at their inflammation score. It's pretty high. And they don't really have a great reason for that other than there's some diet issues. But we were kind of talking, and I think the other doctors they've seen had said, oh, your LDL's fine. Your HDL to
Exactly.
LDL ratio is fine. Didn't check an ApoB. Didn't look at any markers of inflammation. And I was looking at it going, wow, we really got to get this down. I think any one of these puzzle pieces can give us a red flag, but it's really the overall picture. And I think that's the important thing with all this is the context and integrating all these pieces. Do you agree?
Yeah, 100%. And that's, it kind of shows the point that we're trying to do here is that I think broad medicine, they just like you said, they look at cholesterol level and they say, oh, okay, it's pretty much normal. You're good. So far from the truth. That's why you hear about all these people that are like, well, they were healthy their entire life.
Yeah.
They dropped dead. And everybody's so puzzled. Well, it's because somebody was probably just looking at cholesterol and really didn't take into account anything else. They said, oh, you run, you have a pretty healthy diet, yada, yada. You're good. And that might not always be the truth.
Yeah, absolutely.
So
you were going to talk about smoking and how it's good for you, right?
Super good for you. Doctors used to smoke on TV, so, in ads. And yeah, a lot of things that go into this. Elevated blood pressure, the cholesterol, smoking, diabetes, obesity, decreased activity, family history and genetics plays a role. And then, consequently age. Age is a factor in a lot of these things where as time progresses, certain things do develop. And one of them is atherosclerosis, which is just another name for that, coronary artery disease. So
we got to have a big, fancy, hard to pronounce name as doctors, right? Otherwise, how will we know that we're smarter than everyone?
You know what? Exactly. And we need to know that.
It's a $10 or $100 word for clogged pipe.
Yeah, clogged pipe. Don't clog the pipe.
So cardiologists are plumbers basically, and we look at coronary artery disease as a lifetime risk because of all those factors we talked about. Cholesterol is one of them. It's not everything, and we do some CTA scanning depending on your risk group. We might do that, get a calcium score, that kind of thing that can help us out.
Yeah, there's a lot of pieces to the puzzle.
Should we go to heart failure?
Yeah, I think that's a good next one.
So heart failure.
Yeah.
This just sounds bad. I don't want this just based on the heart failure. I don't know who coined that phrase, but I like it. It's not very original, but it's sort of the opposite of the atherosclerosis $100 word. Like this is just what was wrong with his heart? It just didn't work well. It failed.
Very to the point.
Yeah. Heart failure is basically when your heart just lacks the capacity to pump the blood to your body. Most of the time that happens from a heart attack. So, the coronary artery disease you just talked about is the predecessor to this. Heart gets damaged, that part of the muscle, because the heart is just a muscular pump, that, the part affected can't pump any longer. So the capacity to pump goes down. There's some other things that can cause this, right, Chris? And we certainly are working on preventing that coronary artery disease for our patients, but I'd say the other one we kind of work on a lot, especially our younger patients that might otherwise not be tuned into this, would be the blood pressure, right?
Exactly.
Yeah. How many times have you seen folks over the years with heart failure and, they never had a heart attack and they kind of wonder where it came from?
Why? Yeah, I think it's pretty common, super common.
Yeah.
And then you dive into the history and it might be like, I've had untreated blood pressure, never really did much about it for a really long time.
Yeah, felt fine.
I'm a heavy drinker for many, many years. Alcohol can play a role.
That direct tissue toxicity from alcohol to the heart.
And of course, there's always meth.
That is a bad one. Yeah.
That's a bad one.
that can definitely cause this pretty quickly, actually, and quite sadly.
Yeah, very quickly. I've seen, in the past, 30-year-olds with a heart the size of a basketball in their chest.
Yeah,
Um, and
and that's not normal. The basketball size is not normal.
usually not normal. Yeah, it's a
Yeah,
really big heart.
that's really big. Okay. Um, yeah, so pretty much this is, heart failure is not typically a primary issue for people, meaning it doesn't arise on its own. For most folks, there are some people who have an unfortunate genetic predisposition to things called cardiomyopathies, where the heart just keeps growing and thins itself out to the point where it can't pump any longer. But yeah, most of the time it's heart attacks that cause this, or probably the insidious one would be that uncontrolled high blood pressure for a long time. And it might only be, blood pressure of 140, 150 systolic, but going on for 30 years, that can
Yeah.
be a big problem.
Mhm.
Have you noticed, Chris, that people tend to worry about their blood pressure in sort of the wrong time course?
Yeah, exactly. All the time. And, they're like, well, I took it once after I was really stressed out and it was like 180 over 100.
Hmm.
And, it's that, if you run up the stairs for 2 seconds, your blood pressure is going to go through the roof, right?
Well, and
Um,
they've done studies on power lifters. They put an arterial line in them and
Whoa,
measure
what's
the
it
blood
go to?
pressure.
How
Oh,
high?
like 300. Yeah, really high.
Yeah. Their heads aren't exploding, their hearts aren't
No,
exploding.
no.
But it's that long-term effect of untreated low-level blood pressure that's gone on for decades, or maybe a little less.
Yeah,
Um, that it's really that slow, constant damage that is the thing to worry about. Not so much the one-off or two-off elevated blood pressures in a sea of otherwise normal.
yeah, yeah. People tend to have one day where they check it and then they get worried about it for that day, get it corrected, run another prescription, move on. Don't
Yeah,
think about it because it doesn't tend to cause many symptoms at those low levels. But yeah, it's akin to not changing the oil on your car for 60,000 miles.
exactly.
Miss it by a few hundred, it's fine, but miss it by
Mhm.
60,000, it just wears out. I guess we should talk about just one of the things that when heart failure happens, basically the blood that your heart can't pump just kind of goes into your lungs, right? And then you can't breathe.
Mhm.
It's actually a really horrible condition to get. You essentially feel like you're drowning, or like you can't, and you essentially are drowning
And there's
from
not much
within.
you can do about it. Yeah.
Not a lot. Yeah, once you get to that point, we kind of have to just either dry you out, remove extraneous fluid from your body, um, or give you medicines to try to get the heart to pump a little stronger. But
Mhm.
yeah, once you get to this point, it's currently not very reversible. This is kind of doom and gloom, isn't it?
Yeah, so far.
Do we have any good news for people?
At the end.
Okay, at the end. Yeah. Also, these are all preventable. I think that's what we're trying to get at. Is that these
Yeah.
are, these are things we don't want. You and I saw them for many years at the end stage, and now we're trying to jump to the front of the line and say, hey, let's get out of this line. Let's get on a different path here.
Exactly.
I think this is probably the most exciting one.
This is the fun one. Yeah.
The arrhythmias, the
Mhm.
poor conduction. So it's like you ever been to a concert with a bad drummer? Or have you ever been to a concert where they had two drummers?
Oh man, yeah.
Yeah.
Kind of like
um,
that. You don't want your heart doing that.
you don't want the two drummers. That's kind of what a-fib is. A-fib's kind of like atrial fibrillation. It's kind of like having 10 drummers when you should only have one. And that's from the conducting part of your heart, the top, the atria, basically. And they're really only supposed to have one regular drummer, supposed to keep 4 out of 4 time. And then atrial fibrillation happens, and all of a sudden you have 10. You got a guy on the matombres doing the calypso. You've got basically a Latin jazz percussion band up
Not in
there,
sync.
not in sync, and they're deaf.
There's no beat.
They can't hear each other.
Mhm.
And then, so basically the bottom of the heart, the ventricles, the pumping parts, they have, they're trying to keep up, and they just are pumping like crazy. It's irregular. But the biggest problem from this is that then the atria can form clots, and
Mhm.
then you can get a stroke. And so atrial fibrillation, it can be uncomfortable. It can decrease your ability to exercise and tolerate exercise, tolerate caffeine, those kind of things. But the reality is the big problem with this is a stroke risk.
Yeah, way up.
Think, yeah, something like 5 times the normal risk if there are no other factors.
Hmm.
And if you have a-fib, there probably are other risk factors like high blood pressure, right? That would probably be the most common cause of atrial fibrillation. Again, is just
Hmm.
long-standing high blood pressure that's uncontrolled. And again, it doesn't have to be super high. It can just be over the long term. Basically, that top part, the atrial chambers stretch out from having to push so much. And that actually, to use a crude analogy, frays the wiring of the atria. And that's how you get these extra little sparks of electricity. Again, crude analogies, but I think it kind of makes the point.
It's good though, because if you think about the heart in terms of, it's a pump. The heart itself, it pumps the blood, right? It's got electrical circuits throughout it, kind of what we're
Mm-hmm.
talking about right now, that with each impulse of that electrical signal causes the pump. And
Yeah.
then, you have the pipes leading from it to it and from it, bringing, the blood. And really, it's just plumbing, electricity, and a motor, a pump.
And the genetic component to AFib is really interesting. I actually have personally many, many genetic risk factors for AFib, and so I'm really being extremely mindful of my own blood pressure.
Coffee
Kind of,
intake, I'm sure.
well, yeah, I'm trying. I'm trying to get back down to 1 cup a day, but I'm currently at my 3 or 4. I think for me long term, I think I'm going to have to cut down a bit on caffeine and really watch my blood pressure. Luckily, I don't have any of the other risk factors for this. People who drink a lot of alcohol, that's a huge risk factor for atrial fibrillation. And I don't think that gets talked about very much. But again, alcohol is a direct irritant to the heart. And if you're drinking a lot, that alcohol has to get pumped through the heart. So you're giving it a healthy dose. And one more reason to not drink very much.
Exactly.
What's the most interesting risk factor for AFib, Chris, that kind of came to light in the last few years? Do you know what I'm thinking of? I'll tell you.
It's got to be
It's
COVID.
got to. I don't think we should go there. But no, I was thinking more of these omega-3 acid supplementations. And, there was a growing body of evidence that started, I think, somewhere around 2020, 2021, looking at, people who took high amounts of omega-3 fatty acids, which, I think we've been told and been hyping up as heart healthy, right? Omega-3 is heart healthy. But really large amounts of EPA, which, if my memory serves correct, icosapentaenoic acid. Did I say that right?
Mm-hmm.
If I said that wrong, I apologize to anyone.
It's
And
pretty
DHA,
close.
docosahexaenoic, I think, is that one. So those are kind of the commonly found omega-3s in these fish oil supplements, but they're in really large numbers. And cardiologists, I think, in Finland started to notice this pattern of, and they eat a lot of fish there, right, already. And then they studied people who, in addition, took fish oil supplements, and their rate of AFib was just significantly increased. And
Do they have any ideas why?
Just direct action from those 2 fatty acids on ion channel regulation.
That's really okay.
Yeah, so
I was wondering if it was, more to do with, when you source those omega-3s, whether it's from a small fish or a large fish. Many of the large fishes have a lot of heavy metal contamination with mercury, lead, and I was wondering if maybe people were getting bad sources of omega-3.
Yeah, so it's interesting when you supplement it exogenously or externally. That seems to be when these problems happen. But I mean, we're talking, hundreds or thousands of milligrams of these fatty acids a day, which is far, far less than what people are going to get from ingesting them normally. And when they compare them to, what they'll do is they'll replace the fatty acids with fatty acid supplements with olive oil instead as their control. And that's how they basically decided, what was doing what.
Oh, interesting.
This just goes along with, the data that low on the food chain, low in mercury content twice a week has always been shown to improve heart health, right? Across
Yeah.
multiple studies. But those fish oil supplements have never been able to replicate those results. So there's something else going on, whether it's cooking or, I don't think anyone really knows. But there's something else going on when you just eat the fish versus these pills. And it seems that these hyper concentrated doses of fatty acids are probably at best neutral and at worst systemically increasing the a-fib burden on the population. And I know most elderly people, I think, are taking a fish oil supplement nowadays.
Yeah, it's
So
widely recommended.
I thought that was interesting, the how this has played out over the last 3 years, and then just kind of really showing when you latch on to one food item and then you say, this is good, 2
Mhm.
thumbs up, let's go crazy with this. And I think this is a good reminder of moderation, and then just the fact that, not to sound too hippy dippy, but these sort of whole foods, natural foods seem to have more to them than just the isolated ingredients that we happen to study. And
Yep.
so I think that's the case here. There's probably more to the fish oil benefits and the fish oil harms than meets the eye here.
Yeah, because who knows what happens to it during the processing and sticking it into a capsule, Probably a lot is lost.
Yeah. One more thing while we're on a-fib is just, we were talking about that stroke risk. So if you have a-fib, what do you do? There's really no benefit to getting out of atrial fibrillation, right? It's, at least in terms of, you're not going to die earlier because you have a-fib, et cetera, et cetera. It's just, some people don't like it. It's not very comfortable. So for some folks who are young and healthy, don't have any other comorbidities, I mean, first off, they just tend not to get atrial fibrillation. So that class of people doesn't really exist in nature that much. But let's say, you're young, healthy, exercising, for whatever reason you have a-fib. Ablation and things like that are pretty reasonable. You might get electrocution or cardioversion, as we euphemistically call it in the medical field, or chemical cardioversion to bring you out of that. But basically the risk from a-fib is that stroke risk that we talked about. And, doctors, cardiologists, and neurologists are going to use something called a CHA2DS2 score to estimate your risk of a stroke in a given year, and then put you on a blood thinner to try and prevent that potentially. And there are some cool new techniques to avoid these blood thinners. One is called that Watchman device.
Oh yeah,
where really cool, closes up a part of the
I love the
left
name.
atria.
Uh-huh.
Yeah. They did a good job marketing that, right?
Uh-huh.
So the Watchman device basically goes in that part of the heart called the atrial appendage, and that's where 90% of these clots that go on to become strokes come from in people with stroke due to a-fib. And they basically just put this small device in there that essentially closes up that space and doesn't allow clot formation despite the a-fib. So kind of cool that a-fib's getting treated in a way other than just blood thinners. But if anyone wondered why those two go together, that's what that is. We got some other arrhythmias. I don't think we have to spend a ton of time, but you want to tell us about do you have a favorite one? A favorite other one
I
that's
think
maybe a little more fun?
SVT is a fun one, and so is the treatment a lot of the times. But SVT, it's just the mnemonic for supraventricular tachycardia, which just means above supra, the ventricle, fast heart rate. It's a really fast heart rate, and can be anywhere from 150 to 250 beats per minute plus. Usually kind of starts and stops suddenly. There's a couple different forms of it, but there's one called AV, NRT. I won't go into it.
AV nodal reentry tachycardia, I think.
Boom! You just love those big doctor words. With the SVT, it's super fast. It's a little bit distressing. There might be some discomfort, a little short of breath, but it's actually typically not that dangerous. It's more disturbing.
People don't generally die from SVT, right?
Yeah, and that's because it is one of the ones that originates up above the ventricle, up above the part of the heart that's pumping.
Right.
So it's not, and it's a error in the conduction pathway. So it's a electricity problem essentially, or wiring problem.
Hmm.
But there's also a lot of risk factors that can bring it on. Stimulants, stress, anxiety, certain medications, a fever, a lot of
Hmm.
booze.
Hmm.
Um, but in the ER, when you see this, um, it'll be a kind of a classic looking EKG, and there's some kind of fun things you can do to reverse it.
Right,
Um,
because we have drugs that are, speaking of turning off the motor, we have drugs that basically do that. They stop your heart for just a brief second,
yep,
um, and people feel
like they're
like they're
dead.
dying. Yeah, and it's. I mean, they do not like that feeling. Have
No,
you ever had adenosine? I've never had it.
I've never taken it myself. No, but I've given it a
I,
lot, and that the half life of the drug is so short that there's nothing to really worry about. But when you see on the monitor, boop, 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 zzz, you're like,
yeah,
okay, it's the longest like 3 to 6 seconds of your life
yeah,
waiting for
yeah,
that heartbeat to come back because you're like, I just stopped this guy's heart.
and they're
Um,
talking to you.
and then they go, oh, and they get a little gray looking sometimes. And
Yeah, yeah.
yeah, that's kind of the medical one. But the fun ones, and I guess that one's kind of fun. It is a little exciting.
Yeah.
Sometimes, especially when you see these in like a kid, um, you ever dunked a pediatric patient's face in a bucket of ice?
Oh yeah, yeah. The
Yeah,
diving reflex.
yeah.
It yeah
Or had
stimulates the vagus nerve.
somebody blow through a syringe, or
Hmm.
the real dangerous one here is telling somebody to bear down like they're going to take a bowel movement. I'd say that's the most dangerous attempt at converting this.
That's a
Um,
story I definitely don't want to hear or imagine.
Yeah, but all these things, these three, those three, stimulate the vagus nerve, and it's a vagal response that can help bring down the patient's heart rate and kind of reset. So,
What do you mind telling people what the vagus nerve is?
yeah, nerve that runs down, and it controls a lot of things, but one of them is the heart rate, um, and so stimulation of that will actually decrease heart rate.
And then if that keeps happening, you can go see your friendly electrophysiologist and have them burn the accessory wiring out of your heart, which sounds scary, but it's pretty cool.
So we just got through SVT, kind of one of the non-dangerous rapid heart rates. And Ryan, you want to talk a little bit about some of the ones that will kill you?
Yeah, there's some dangerous ones that are not
Mhm.
good for you, and
Really, really not good.
yeah, they're less than desirable. One's called ventricular tachycardia, and then again, atria are sort of the top part of the heart. The ventricles are on the bottom. The ventricles also have a lot of wiring. It gets complicated because early on in the heart's architecture, the wiring is sort of confluent, sort of like a power main line, right? Like all the lines are in there. It's one conduit. It's very easy to follow, and then you get to the ventricles, and that's sort of the suburb. It's sort of the couple cul-de-sacs there, and so the wiring has to kind of splay out in multiple directions and has to be coordinated, and that's the issue, is that there can be a discoordination. Would be called ventricular fibrillation. That fibrillation is just that discoordinated pumping where like one part of the heart's beating while the other's not, and it's not organized. It can't actually move blood. So this kills you pretty darn quickly, and this can be the result of um, having a heart attack, so a really large myocardial infarction or heart attack
Hmm.
can do this. Likewise, this can be the result of maybe an electrolyte abnormality like potassium or calcium. Maybe you got hit by lightning, and then that in and of itself can lead to a heart attack. So these are, ventricular fibrillation is basically your cardiac arrest. That how a lot of those start. Good news, super treatable if it happens within eyesight of an AED, automatic external defibrillator, um, or in a hospital with a really fast, really swift resuscitation team.
Hmm.
If this happens to you while you're alone out in the mountains skiing, you're not coming back from that trip.
No.
So, yeah, this is one to avoid, and basically all the risk factors that we don't
What
do
to
this
avoid?
recreationally.
Yes.
All the risk factors we already talked about, and all the preventative measures are preventing this. Some people do have, you know, genetic abnormalities that predispose them to this, other acquired problems that predispose them to this. And so some people do have a built-in defibrillator, plus minus a pacemaker. And so some folks listening to this may even have one of those or have a family member with one of those. And MRIs are not your friend, probably, if you have one of those. And then the other really big dangerous one would be ventricular tachycardia, slightly less dangerous in my mind. You can be awake and talking with this one, but yeah, basically just a really fast,
probably not for long.
Heart rate. Probably not for long. Really fast heart rate, around the 200s maybe, depending on your age, that originates from the bottom, from the ventricles. And again, can be from a heart attack, can cause a heart attack, can be from electrolyte problems. Recreational drug use can definitely do this. The stimulants, cocaine, meth. Treatment for this is, usually electricity, so defibrillation. If you've seen the show ER, rubbing the paddles together. Though nowadays they're just really.
Have you ever rubbed the paddles together? I don't even think I've ever seen a paddle.
I have
Did
done.
You?
I have done the old school paddles. Yes.
Where was that?
Well, it's when we had a pad failure. We couldn't get the pads to stick.
No way.
Yeah.
Wow.
So yeah, I've used those, and then I've used the internal. Have you ever used the salad tongs, the internal defibrillators?
I have, yes.
Yeah, those are.
That's a whole different story.
That's a whole different. Yeah, that's a whole different one.
Internal.
Yeah, yeah. If you have internal defibrillation, odds are you have a really advanced medical team already working on you. One last dangerous arrhythmia or problem with your heartbeat. Chris, what's this last one? And this is less exciting on paper. Like the EKG is not super fun looking for most people, but this one's less. It's less glamorous than the tachycardias, but to me, it's more scary because it's harder to fix. I can always fix the other ones.
It's a slower fix. It's a slow heart rate. It's called bradycardia or slow heart rate. It's typically defined of a heart rate less than 60, but it can go down. I mean, it can go way down. I've seen the 20s and 30s.
It could go all the way down to zero.
Yeah, down to zero.
That's a slightly different thing. One is bradycardia, zero is asystole, I suppose.
Yeah, and there's a lot of things that can cause this. Age. As we age, the conduction system, those electrical impulses go through, becomes less efficient. There's a lot of medications. Somebody is on something called a beta blocker or calcium channel blocker. That can slow the heart rate, especially in overdose or higher doses. You can have something called heart block, sick sinus syndrome, or some of the things. Something as simple as thyroid, exactly, like hypothyroidism. Certain infections, especially surrounding the endocardium or myocardium, which is the sac or the muscle of the heart. And then elevated electrolytes, like a high potassium, can make your EKG look real scary. And this is probably one of the scary ones because this is not a shock fix. This is a slower fix, to bring that potassium level down. And the repolarization of the cells in the heart is all, if you have a high level of potassium, that repolarization as, electrolytes go in and out of the heart cells isn't as efficient, and it just is bad. It's scary.
Yeah. I mean, in a way, it is a shock fix, right? A pacemaker, if you have access to it, or if you end up needing one. But for those middle cases that are still have a blood pressure,
which is always
reversible
nice.
Cause.
It's always nice to have the pacer available to give you a little bit of time to fix the underlying problem.
Right.
I'm
you
thinking
talked about. What's that?
I'm thinking of a story of putting the pacer on. We needed it on now before we could get some sedatives and pain meds on board, and the person is literally getting shocked.
No. Yeah.
Oh,
it's not. Yeah, it's not comfortable.
Oh, every beat of the heart.
Yeah, external pacing through the chest and through the skin is really very uncomfortable.
Very uncomfortable.
Yeah. And then internal pacing is its own, through where you thread a catheter through the large neck vein, through the jugular, literally going through for the jugular, thread a wire that is hooked up on the other end to basically a battery pack, basically a TENS unit.
Yeah.
That that you literally just bump the wire into the heart, like into the right ventricle, and then you just turn the battery on.
I got to tell this story.
Yeah.
Working in one of the ICUs, a cardiac ICU, and we had a patient with a heart rate in the 20s, and it was due to a number of different things.
We should clarify, not normal. That's a
abnormal. And so he had one of those internal pacers in. You know, you have to put it on. It's a wire that goes down into the heart and kind of direct the electrical to beat the heart from internally. And he fell asleep, had a terrible nightmare, and woke up, pulled out his pacer out of his neck.
Oh my God.
Pulled out all his IVs, took off all his clothes, and got about 25 yards down the hallway screaming.
Did he have them Did he have them like in his hand like this?
No.
Oh,
his hands were just running down the hallway. And before he dropped, you know, when his heart rate you can't run with a heart rate in the 20s.
Yeah, that's hard.
So his obviously blood pressure plummeted, and he was fine. We got him back on. We got the pacer back in. We're like, what the heck happened, man? And he's like, you know, he had this dream that he was in an alien spaceship being like tested on, and he thought he was trying to escape. He had,
were you all using like ketamine or something? Was that where the spaceship came from?
I'm not sure where the spaceship came from, but I could see that. You know, you get in a hospital, you get a little delirious, things are weird.
Yeah.
You have wires in your neck and IVs everywhere and things beeping, and you know. But that poor guy,
very, very spaceship-like.
Mm-hmm.
Do you remember the call room in the CCU? Do you remember the because you're constantly having to replace
This is
potassium.
the same ICU I'm talking about. Yeah,
because you have to replace potassium like every day in everyone there. It's always going down a little bit, so you're constantly ordering potassium for everyone. And I remember someone probably on hour like
usually at 3:30 in the morning for some reason
it becomes extremely urgent at 3:30 in the morning. But yeah, someone was probably on hour like 33 of their call shift and wrote, when I get out of here, I'm going to buy a potassium mine. And
did you write that? Was that you?
No, I wrote some different stuff that we can't say.
Yeah, there's some bad stuff on that bunk bed.
Yeah. No, but I have always thought, man, where does all that potassium come from? Where do we get it? It's probably hopefully they don't get it the same way as like the lithium and the what's the bad one in the phones now?
Oh, cobalt.
Cobalt, yeah. I hope they're not getting that potassium the same way they get that cobalt.
I guarantee it's pretty bad.
No, I hope not. And I hope it just grows on potassium trees and they just pick it.
They milk bananas. Banana
what do
milk.
They call it fair trade potassium. I hope it's fair trade. All right. Well, Chris, so we covered a lot of stuff here. And for the one person that's still watching this, hi, Mom.
That's a high expectation.
You know, we'll just go back through it. So we had some clogged pipes. That's coronary artery disease and heart attacks.
Yes.
We had heart failure. Your heart just can't squeeze anymore. The water or the blood, which is, you know, water in this crude analogy, backs up into your lungs. You can't breathe, can't lay down. Then we had arrhythmias where your heart just doesn't beat like it's supposed to, electrical problem, conduction problem, sometimes electrolyte problems. And then we had congenital heart disease. I think we're just going to kind of skip that, right? Because that's another topic. If you have that, you probably know it. But yeah, basically the prevention of all of these, the nice thing is we can prevent a lot of these the same way.
So much of it. Or at least manage it, you know, keep it not as severe.
And, you know, I always like to say the best tool you have to prevent disease is to pick your parents well.
And not get
genetics, older. Well, yeah, not get older too. But yeah, we have some, as I said earlier, I have a number of high risk variants for atrial fibrillation. And we can look at that both for a-fib. There are some coronary artery disease, variants that we can look at. And then what's pretty interesting, and I still don't know why this isn't used widespread, but there are a number of people, and I am actually one of them, again, looking at my own genetic testing results, there are a number of people who, if they have a heart attack, they do not respond to the typical blood thinner that we would put people on to prevent another
Yeah.
heart attack, Plavix or clopidogrel, which basically inhibits platelets, right?
Isn't that like
Um,
25%? It's
yeah, and
quite high, right?
it's just, I don't know if it's quite 25. I'd have to look back at the PGX data. I think it depends on your population too. But in like Northern European white people, which, here we are, it's pretty high. And so, yeah, we're literally treating heart attacks here in the United States blindly, as if everybody is the same, um, when this drug doesn't work on a significant number of the population.
Wow.
And this is like verified. This isn't, this isn't even like cutting edge or bleeding edge. This has been known for a while. There's a consortium on it, an international consortium. So why we don't do that, I'm not quite sure. There's also pretty significant genetic variability attached to statin therapy, and how effective that is, not only at improving the numbers, but at improving the outcomes that we really care about, heart attack, stroke, death, right? So I think this is underutilized. So I certainly try to incorporate this into just my initial overview of, where people are at risk. And I think we used to do this, or we still do this, but one of the big parts of getting a history in a patient, right, is that family history.
Mm-hmm.
It's basically the non-technical or poor person's genetic test, right? It's saying, like, what do we think the genetics are here? But it's really rough, because you can have recessive conditions that wouldn't have shown up in either of your parents. You can have variable expressivity of certain variants. You can have synergy, and your lifestyle might be different than theirs. So I
And
think
most people don't know, like,
no.
how often do you get a family history that's like, I have no idea. And you're like, all right.
Well, not to mention, if you go back to, people will often, like we alluded to earlier, people will often go back to their grandparents, right? And I think for me, that's not that useful, because healthcare was in the absolute stone ages. We had just discovered medicines that kind of worked when those people were alive, right? Antibiotics are not 100 years old even. And so the nuance with which their diagnosis was listed is probably zero. And so everyone died of a heart attack or bad humors, or, something was in the ether. So I think it's unfortunately not that useful. And then even people who have, looking at their parents, it might have been the 60s or 70s when they had a diagnosis. Again, not that useful. Like, the nuance wasn't there. When you had a heart attack back then, what happened? They said, a cardiologist came in smoking and said, you've had a heart attack, see? And they put you on, your tick is no good. And they put you on a heparin drip and sit you in the corner. And then, I don't know. That was pretty, then I think they put you on bed rest. You probably were just on bed rest because you had congestive heart failure.
Yeah,
So
severe reduced cardiac function.
Yeah, so it's amazing to me that this is still not standard, and we certainly try to make it as such because of all those reasons. What else? How else do we prevent this?
I think one of the big ones is exercise.
Mm-hmm.
It's kind of crucial for managing and improving heart disease, kind of all the forms. And there's two, when you think about exercise, there's two, I guess maybe three types. One is that cardiovascular, exercise, walking, jogging, cycling, swimming, rowing, and which strengthens heart muscle, improves circulation. And then there's the resistance or the strength training that helps build muscle, improve metabolism, which can kind of lead to having overall being heart healthy. The thought is, and the AHA, the American Heart Association, recommends that there's two kind of levels of exertion with moderate exercise or moderate intensity. You want to think of it as you're breathing heavy, but you can still like carry on a conversation with a person you might be running with or walking with. And then there's vigorous intensity where you're really breathing hard and you're not really quite able to breathe in full sentences. So that's kind of a good way to like split up those two intensity levels. If you're going to do just kind of moderate level intensity, they recommend 150 minutes per week. If you're doing straight out vigorous intensity, 75 minutes per week. And that's kind of the minimum, for those two.
Yeah.
As far as strength training goes, the recommendation is hitting all major muscle groups twice per week. And kind of the third type of exercise to consider is balance training and
That's a good one.
flexibility, just for overall health improvement.
Yeah.
I think if you incorporate those three, it's a good kind of well-rounded way to address prevention and management of heart disease.
Yeah, and I was just thinking too, as you're saying that, I can think of all these other benefits to everything you're saying, with the cardiovascular exercise. Um, there's the mental improvements that come with that. We talked about, dementia recently, and, similar numbers on the minutes or hours per week of cardiovascular or aerobic exercise, had a huge impact, probably the biggest impact on reducing your likelihood of developing dementia.
Yep.
Compared to anything else. Certainly better than any medication, right? That we reviewed.
Far
And then, the strength training or resistance training, whatever you want to call it, basically lifting up heavy things and putting them back down. That has, impacts on bone health, hormone health, right? Hormone balance tends to improve, with strength training. For women, prevention of osteoporosis, increasing your lean muscle mass will happen with that. And then that improves your metabolic rate. It's going to improve your insulin resistance, improve your blood pressure. I mean, it's just
on and on.
Yeah, it's just roses all around, right?
And one of the big things too, if you think about like one of the metrics that they measure aging by, is can you stand up from sitting on the floor, which may not seem like a difficult task, but as people age, you'd be surprised at how many people need assistance or simply can't do it. And so remaining that strength, the balance as well, and being able to simply stand up from sitting on the floor. It's one of the metrics that we measure aging by, and keeping that as long as you can, to the best of your abilities you can, is a huge marker of aging overall.
Yeah, it is interesting that you talked about splitting up the aerobic exercise into kind of two groups like that. There's, I think people like to talk about the zone 1 through 5. And so I think if it depends on how nuanced you want to be. If you want to go put a heart rate monitor on, you can definitely do that. I've been there. And I actually really like that for some patients. Get the heart rate monitor data and really see, because if, like what you were saying, if they go from essentially what you're saying is zone 2, which is 60 to 70-ish% of the max heart rate. You should be able to talk, right? You should be able to speak with ease while you're doing whatever you're doing. And for different people, that's going to be different things. That's why all those walking studies, come out that say, oh, you don't actually need to run. You can just walk. I mean, it has nothing to do with running or walking. It's just that some people, walking puts them into zone 2,
right.
And zone 2 is beneficial. I don't personally think that means you should settle for walking being your zone 2. I really don't. I think you should probably endeavor to get to the point where, and maybe you can't handle impacts from running with knee issues or something like that.
Rowing,
stationary
swimming,
bike, something.
There's a lot of things that are low impact.
Something. Yeah, if walking down the block at sea level on flat ground is putting you into zone 2, almost 3 threshold, yes, you should start out walking. But you need to do a lot of walking so you can bump it up a little bit. So that's how I feel about that. But what was interesting about what you said is that really the improvement, if you get into, say, zone 4, those improvements, those cardiovascular improvements, really aren't there. And so I know I personally, when I go exercise, I don't know if you're like this, but I kind of like to punish myself. You've seen that. Like I like to really feel dead at the end. And that's one of the hallmarks of the zone 2 cardio, is that you almost feel like you didn't do anything afterward.
Yeah.
And that's actually ironic, because that's the best thing you could do, is zone 2. So just if you're a knucklehead like me and you want to just go beat your head against the wall when you exercise, that's fine. There are other good things about that, but it might not necessarily be improving your cardiovascular health.
Yeah, to the degree.
Yeah. I took us on a tangent there. Sorry.
It's cool.
Yeah, I think the next thing that people could do to impact their risk of heart disease would be to, focus on nutrition.
That's a big one.
Yeah. And, gosh, all these are, it's not like any one of these is enough, right? These are all pieces of the same puzzle.
Mm-hmm.
And really you get a synergistic effect from trying to optimize all of them. But I think nutrition is definitely one of those that has been neglected for a long time by typical medical care, which is why we're focusing on it so much. So yeah, I had some things. Chris, do you have to be a vegetarian or a vegan to minimize heart disease risk?
You do not.
Okay. It's okay if you are. that's totally fine. You can definitely do it in a healthy way, for sure.
Yep.
But do you remember this guy, Dean Ornish? Did you ever hear of him?
I remember reading him. That was quite a while ago, wasn't it?
Yeah, I mean, I think he's still I think he's still a cardiologist in Boston, but he was like Bill Clinton's cardiologist. Bill Clinton had a heart attack, or a series of heart attacks, and like kind of had famously just like eaten McDonald's and really liked French fries, and then went on a vegan, ultra low fat diet, and heavy emphasis on whole grains. And you see him now. I mean, he's super slim. He almost looks like one of those bobbleheads, right? Because he still has like kind of a large framed head, and then his body is just like super super thin. I think Al Sharpton might be one too, but I don't want to libel or blaspheme anyone, so we'll stick an asterisk on Al Sharpton. But yeah, a lot of these famous people have gone to this guy, and they do this intensive intervention where they do essentially no animal fats, ultra low fat, really high fiber diet, super high amount of whole grains, and it's one way to do it. It's definitely one way to do it. And I think there's also ways to do this where it's not so intensive. And, I think we try to strike that reasonable moderation for people so that they can stick with
balance. It's a good balance.
Yeah. And like we talked about, this ultra low fat, ultra low cholesterol diet is not really shown to be that beneficial in terms of heart disease or cholesterol numbers. We reviewed in the cholesterol video, your total daily cholesterol intake isn't necessarily correlated linearly with your actual serum levels, because your body's just so in control of that, in terms of its uptake of cholesterol and in terms of its determination of cholesterol balance in the liver. And so to think that you're going to trick that is probably not going to happen. And really, saturated fat is your main dietary tool to modify that. And like we talked about, there's a ceiling to that effect at about 9% of your recommended daily intake of calories. So if you're on a 2,000 calorie diet, around 18 grams of saturated fat, 3,000 calories, around 30. And so below that, it really depends. There's individual variation in terms of response. And there are even these folks, these paradoxical hyper responders to an ultra low fat diet. And basically they take these folks and they put them on really low cholesterol, really low fat diet. And what do you have to replace that with, Chris? If you're doing, low fat,
carbs.
Low cholesterol, it's always carbs, right?
Carbs come in.
Yeah, so which can be fine. It's okay to replace some of that fat with complex carbohydrate. But what happens with these folks is their numbers actually shoot way up because their body now has this essentially like a starvation signal that says, oh, hey, we don't have any cholesterol intake. We have no fat intake. We've got to mobilize and kind of build up and prepare for
Conserve.
this. Yeah, prepare for this. What apparently is like a long winter or a famine is the
Hmm.
theory behind this. And their LDL might shoot up like 5, 10 times. I mean, it might be into the 4 digits. They go crazy. So there's even these people that you put them on a vegan diet and low fat diet, and they have a exponential increase in risk. So I think moderation, follow what works, and then if you don't retest, if you start a diet intervention and you don't retest your cholesterol, you don't retest your lipids, you don't look at what your vitals, like your blood pressure, your maybe if you're consistently working out, which we hope you are, what's your what's your bench press or complex chain movements, like you know Turkish get up, how's the weight capacity changed on that? I think those are all really important. And oftentimes people just glom onto a diet and then don't recheck it until they either feel better or feel worse. And there might be something
Yeah.
going on behind the scenes.
I think that's a really important point you bring up is that, once you start an intervention, whether it be diet, exercise, medications, whatever, it's having that follow-up monitoring and seeing,
Yeah.
did it make a change? Did it make things worse? Are things trending in the right direction? And following those metrics that we look at over time, to kind of tweak, because one thing isn't, it's not a one size fits all thing. People are very different. They have variations in genetics and metabolism and everything really. And so
Yeah.
following that over time, and I think it's important to note that this is one of the first things that we start with at Sapia is diet monitoring, your diet logs,
Yeah.
seeing where you're starting from, and working forward and moving forward with that.
Yeah. I mean, I always want to listen to patients, right? So a lot of times people will come in and they'll say, I want to get treated for this. I think this is, I know someone who took this medication and it seemed to work out well for them. And that's great. Like, we can always talk about doing that. But how many times have you had that scenario where someone comes in knowing they have this problem and they want this treatment, and then you look at the dialogue and it's like, wow, there is so much room to move on this. You change that, and then suddenly, the condition that they came in for is no longer there. They're eating so much better and they feel so much better. So yeah, I agree. That's why we start here, because why would we put you on a bunch of meds? I mean, if we have to, yeah, let's do it. But let's maximize these interventions that have synergy throughout your body and throughout various systems in your body and with various outcomes, whether it's aging, cognitive function, preventing heart disease. Why are we going to throw that away or not look at it, not look at the nutrition and just jump straight to meds? It makes no sense to me.
It makes no sense, especially when a lot of the research points to, things like diet, exercise, stress management, sleep have
Yeah.
such far reaching effects on all of the health things that we talk about, cardiovascular, cognition, really everything. And
Yeah.
it's so powerful. And, when done correctly, to be able to address a wide range of health, health concerns, it's super powerful, I think.
Yeah. What about stress management?
That's a big one. Stress is
I don't personally know how to do that. Maybe you do.
I'm learning. I think we're all learning, and that's okay. Stress is hugely involved with heart disease, and managing it is something that's going to help reduce heart disease quite a bit. You don't think about it, but chronic stress, that not just like, oh, I have have a deadline coming up. I need to make this, over the course of a week or so,
Hmm.
as a one-off versus I've been stressed out for years, due
Hmm.
to any number of factors.
Hmm.
And that long term, that chronic stress is a driver for elevated blood pressure, high cholesterol, and a lot of other unhealthy lifestyle choices. You
Yeah.
might not be
Insulin,
sleeping
insulin
well,
resistance.
insulin resistance. I mean, there's a real chain of events that happens, especially between stress and sleep.
Hmm.
Um, and it might just cause you to behave more unhealthy. You're binge eating, you're not sleeping correctly, you might be drinking more alcohol, you might be smoking.
Hmm.
Those unhealthy stress management tactics that funnel down and kind of are all the things that we've talked about leading to increased heart disease. So step one in this is kind of recognizing that you are stressed out. You
Hmm.
might notice that your heart rate's beating kind of fast, you're tense, you're really irritable, you're having a hard time with concentration. There's kind of a lot of different manifestations of stress. I
Hmm.
think people are pretty cognizant of what a lot of those are. So step one is kind of realizing, am I stressed? I would say that most people, especially in the United States, are hugely stressed out. And I think
It is part of our culture.
it's become such a norm. It's like there's almost a badge of honor that goes along with the grinding. I'm grinding out.
Oh
I'm
yeah.
working hard. I'm
Yeah.
stressed to the max every day. Rah! Like, hey, you're gonna die early. Like, there's okay, grind away. And
That's
I'm
like,
not down in the grind. Like, we've all grind. We went through medical school and residency.
yeah.
It's a
Yeah, yeah.
grind for years and unhealthy habits, and we've been there. We get it. Um, but it's not healthy. Um, but there are a lot of things you can do to modify stress and manage your stress. And it's really all the things we've talked about, right? Eating a healthy diet, regular exercise. Regular exercise releases
Hmm.
endorphins. It lifts the mood. It's a great chemical. I don't know if anybody's ever gone out. They're real pissed off, having a bad day. You might go to the gym. You might go for a run. You might engage in some healthy like exercise activity. And after you're like, hell yeah, I feel so good.
Hmm.
And endorphins, it's a powerful chemical um, within our bodies. Getting good sleep to help with stress, um, decreasing alcohol and tobacco use that you might use as kind of a coping mechanism for stress.
Hmm.
Engaging in relaxation tactics, deep breathing, yoga, meditation, progressive muscle relaxation, all great things you can do. And, going back to the grind part, having good time management is something that can improve stress.
Hmm.
If you're coming up on a deadline or, you wait till the last minute and you procrastinate like I do for every single thing in my life, um, your stress gets high. The day before you're like, oh my gosh, let's do tomorrow. Rah. Um, Having social supports, talking it out, talking with friends, family about what the stress things. I think the stress thing ties into sleep as well, and um, I think that's something important to talk about, not only in terms of stress, but how it relates to heart disease.
Hmm.
If I may, um,
Please, you have the floor.
I have the floor. So there's two parts of kind of sleep. You want to think about it in terms of quality of sleep. Are you sleeping through the night? Are you going through the correct rhythms? And quantity. Are you getting enough? And that's a number where everybody thinks it's 8 hours, but really there's quite a variation. Um, some people might need 6. Some people might need 12. So really, that might be more of a individualized number in terms of like the quantity of sleep. But it has a huge amount of effects in the body in terms of stress, in terms of heart disease. One of the biggest ones is blood pressure control.
Hmm. Yeah.
When you sleep, it gives you that time to, the blood vessels are relaxed. So it's really important for blood pressure. It's really important for stress reduction, like we talked about. Um, there's quite a decreased um, inflammatory response that happens during sleep. So that
Hmm.
going back to the cardiovascular disease things that we talked about, glucose metabolism,
Hmm.
really affected by sleep, weight. There's a huge interconnection there. Uh, Sleep is really related to a lot of the hunger regulating hormones that you might have during the day.
Hmm.
You think of sleep apnea. If someone has sleep apnea, that can lead to cardiovascular disease, either through high blood pressure or other terms. Um,
Hmm. It's also
and
just
then,
not good to have your oxygen saturation being like dipped down to 50%,
yeah,
25
not
times a
great.
night, right?
Exactly. Um, Hormone control, a lot of your stress hormones, appetite hormones, metabolism hormones are regulated and monitored through sleep.
Yeah, I
Mental
mean, I
health.
know we were just talking about how we can tell immediately, well, maybe immediately strong, but pretty readily if someone gets really bad sleep or otherwise is kind of redlining. You can see that on their hormone panel oftentimes. And yeah, you can sort of treat that with, if they're a guy, TRT or some other stuff, if they're a female, but um, a lot of times just sleep is what it takes to improve those. And you actually end up not needing the meds in the first place.
Yeah. And I think, as technology is so intermeshed in our lives, I think that people's sleep is, when you talk to people, no one, I don't remember last time I talked to someone that's like, I slept awesome. Like, pretty rare to hear that. It's usually, oh man,
Yeah.
I didn't sleep well, and I wonder how much technology is having an effect on this, using the screens late into the night, having your mind, you know, processing information, emails, texts,
Yeah.
all these inputs, sensory surges right before we go to bed. And then the moment we wake up in the morning. And I wonder, um, I imagine that's having a much larger effect on sleep than maybe we realize.
Yeah, it's funny. I can't remember where I heard this, but there's all this content online now where it's like either like Navy SEALs or CEOs, and they kind of brag about like, or fitness people, they'll brag about, I got up at 3 a.m. There's the famous like Jocko
Mm-hmm.
Willink shot of the watch at 4 a.m. every day.
Mm-hmm.
And I heard someone say the other day, yeah, if I was like a billionaire, top two rich person in the world, and I wanted to, or I would also trick them into getting up at 4 a.m. and getting no sleep
That's
to take
awesome.
a competitive advantage. I didn't say it; they said it much more eloquently than I just did, but I
No,
thought that
that's
was
good.
pretty funny. I feel like we're all
So
kind
let.
of getting tricked into that sometimes, where it's like,
Mm-hmm.
yeah, we run kind of full throttle for a while, but you always end up having to take that break. It's so much better um, when you're able to moderate your sympathetic tone and your stress kind of earlier and more frequently rather
Yeah.
than wait for the crash.
Plus, in that example, how reasonable is that? Because you hear about this all the time. I get up at 3, I get up at 4. Well, if you're a regular person working Monday through Friday, 9 to 5,
Yeah, how is that
so you're getting up
possible?
that much earlier before you need to go to work, which, I mean, hey, if that's where you want to spend the time of your day, alone and in the dark, okay. Um, but that means also that you get home and essentially have to be in bed within, a couple of hours. And
Yeah, exactly. Yeah.
if you want to get some meaningful sleep throughout the night. And so I think a lot of the messages, I see that all the time. It's a lot of bragging, I would say,
Yeah,
on
exactly.
Twitter and across wherever of, how early people get up and start grinding away super early in the morning and doing their daily routine, their morning ritual that might be take 3 hours and, is preventing them from actually getting any, maybe meaningful stuff done. So,
Yeah. It's another example of that extremism where we, latch onto one thing, it's productivity. It's, I don't know. That's great. I mean, I like to be productive. I know you do too, but um, yeah, if productivity is the only defining metric of your life, I think you need a therapist.
yeah, there's something else going on.
Sorry, there's some other stuff to life. And I think that kind of gets us to, we were, briefly going to talk about community,
Hmm.
and that just the effect that just having good community, social relationships, we talked about it in our dementia talk, and cognitive health talk, where that remaining engaged and having high quality relationships, both friendship and romantic and family, that is preventative, and more than anything, right? And not only that, it's also just very enjoyable. I mean,
Exactly.
it is the best part about life.
Hmm.
But we were talking earlier about diet and stress reduction, and it's actually interesting. All of the Mediterranean diet studies that we've looked at over the years, they kind of always have this asterisk because they often are in Greece or Italy or Spain, and the big asterisk when interpreting these papers is always, well, yeah, but aren't they all really into family and friendships and relationships over there? Like, isn't that
Yeah.
part of it?
It's not a
And
meal alone. It's a meal with everyone.
exactly, yeah. So I think it's actually hard even for researchers to tease that out, right? Um, yeah, it's very interesting.
Back to the commune.
Back to the yeah, yeah, maybe. Um, they have their own. Those communes seem to have their own set of problems based
Yeah.
on watching the Netflix documentaries like Waco and Wild
Oh
Wild
my.
Country. I'm not sure
Yeah.
I'm quite
Yeah.
ready for commune life yet.
Uh.
But thank you. I appreciate the invite. I might decline. Let's just stick to visits.
Fine.
I'll stay in the hotel. All right. Well, and then I think just the other stuff that we're talking about, reducing heart disease, it's all the other lifestyle things, drinking less, smoking, hopefully not at all. And
Hmm.
then, stimulants, street drugs, meth, crack cocaine, hopefully,
Yeah. Stay
hopefully
away
not
from
at
the heavy
all.
stuff.
I mean, cocaine is on an upswing in the, like in white collar US, I think.
It seems like it
Um,
has been for a very long time on the upswing.
yeah, I think and I think there are numbers
It's
that
everywhere.
indicate that as well, in addition to anecdote. But yeah, and it really can't be overstated how bad that is for your heart.
Hmm.
Not like short term, in that 24-hour period, you're orders of magnitude more likely to have a heart attack even at a younger age, after some of these drugs. And then long term, they have significant detrimental effects in
Yep.
remodeling the musculature of the heart. Some people are extremely susceptible and don't even have to use that much. So yeah,
As well as neurotransmitter stuff when you're talking about the brain.
yeah.
There's a
So yeah,
huge.
it's, to quote South Park, drugs are bad. Try not to do those drugs.
Did you see the study on comparing long-term effects of cocaine use on alcohol mixed with energy drinks, like the classic vodka Red Bull? Same,
No.
same, same.
Hmm.
The negative effects cardiovascular wise are the same between the two. So it might be
Interesting.
also a good idea to think about. All right, am I drinking 10 vodka Red Bulls a night? That stimulant mixed with alcohol could also be doing quite a bit of damage cardiovascularly.
When they do a study, and at the end they ask people, which group do you think you were in? Were you in the treatment group or the placebo group?
Hmm.
And if it's a really good study, you want them to be about 50-50, right?
Yeah.
I wonder what I wonder what the accuracy was in that study about which group you were in. I bet people probably knew pretty well which treatment arm they were in.
Uh-huh, I would say.
Yeah. I
It's
wonder
hard
how they
to.
got that one through IRB. That's interesting. Well, cool, Chris. Well, is there anything else to add on heart disease and how to not get it or why you don't want it?
No, I think we kind of covered the gamut, and a lot of these things at Sapia we can help with. The diet, the exercise, the monitoring, a lot of those components that we've kind of discussed above. You might be having a hard time deciding where to start, or what's important, what's not. Where's the bulk of the improvement going to come from? And
Hmm.
that's something that we're happy to talk about, discuss, work on.
Yeah, yeah, it's a huge part of it, and yeah, I think that's a big reason why we're there for people,
Mhm.
is to prevent these things so that way you don't have to deal with all this. I mean, who wants to have heart failure and be on a blood thinner and all that? I mean, it'd be much better to skip it. right? So
Skip it. Skip.
just skip that part. All right, everyone. Thanks for watching. We really appreciate you tuning in. If you would like to see us and see how we can help you prevent heart disease, dementia, and all those other things that none of us want, go ahead to sapiahealth.com and you can sign up for a free info call with Chris or I, and we can help you out there. Thanks.
Thank you. Bye.
Bye, Chris.